Primary amenorrhea is defined by a girl who has never had her first period. This is abnormal only if she's reached the age of 16 before the onset of menses. Likewise, if a girl has yet to develop any secondary sex characteristics by the age of 14, that's abnormal. Otherwise, it may simply be chalked up to constitutional growth delay. Basically, what you're going to have to do on every test question is decide, does this girl need reassurance or does she need a workup? So if she has not had secondary sex characteristics by 14 and has not bled by 16, she warrants a workup. The workup usually involves getting a wrist x-ray to determine her bone age relative to her chronologic age and a beta HCG to make sure she hasn't gotten pregnant. FSH and LH can be useful. What I'm going to do first is give you a method of working through how to think about someone who is having primary amenorrhea. And then we'll go in and talk about the more interesting diseases, the diseases that you're going to get tested on. So here's my method. What I want to be able to do is assess whether or not she has the endocrine function to produce secondary sex characteristics and has the endocrine function to produce an endometrium that can bleed. I want to test her axis. I also want to assess her anatomy. That is, does she have a uterus from which to bleed at all? The way you can do this is by assessing secondary sex characteristics. Has she developed breast buds? Is there axillary hair? Is there pubic hair? Has she undergone the changes of puberty? And then for anatomy, you use the ultrasound and asking yourself, does she have a uterus? Because someone who has the capacity to produce an endometrium with endocrine function, that is someone who has started to develop secondary sex characteristics and does have a uterus from which to bleed, has a very narrow differential, which includes stress and anxiety and a patient who's pregnant before the first period. If she does have the ability to produce the endocrine function to bleed, but has no uterus from which to bleed, she'll look like an adult woman on the outside, but is not a woman on the inside. Compare that to someone who is breast negative and uterus positive. That is, she has the internal anatomy from which to bleed, but lacks the endocrine function. And finally, we're not going to talk about it, so I'm going to write it really small because it's based on enzymatic deficiencies that you're just not going to see. If she has neither the ability to produce hormones nor the anatomy from which to bleed, this is a very rare condition. We're not going to talk about it. So let's go through each of the three categories, giving examples of each one. If someone has the ability to produce estrogen and progesterone and a uterus to respond to it, the causes of primary amenorrhea are very narrow. It generally means that she's anorexic or is having intense weight loss, has become pregnant before her first period, which can happen, or she's bleeding and you just can't see it. That is an imperforate hymen. You can detect these simply by looking, that is inspection, taking a decent history, and getting a beta HCG to see if she's pregnant. If she has the endocrine function to develop secondary sex characteristics, but lacks the internal anatomy to bleed from, she has something gone wrong with embryologic development. This is the case in Mullerian agenesis, and testicular feminization. These are separated by the testosterone and a karyotype. In Mullerian agenesis, she is genetically female. Because she's genetically female, she'll have normal levels of testosterone. In testicular feminization, the patient is actually genetically male. And because the hypothalamus knows that there are testes, they're trying to rev up the testosterone production to turn that person into a male. So testosterone will be elevated. In someone who has the anatomy, but not the endocrine function, you have to figure out why the axis is broken. This is going to be craniopharyngioma or other anterior pituitary tumors, Kallmann syndrome, or Turner's. Here, the FSH and the LH give you some great detail. In craniopharyngioma or anterior pituitary tumor and Kallmann syndrome, you have a decreased ability to produce FSH and LH. You separate them by the MRI. In Kallmann syndrome, there is no mass. In craniopharyngioma, there is. In Turner syndrome, on the other hand, she lacks ovaries. The axis is deficient at the level of the ovary, and so the axis is going to upregulate FSH and LH in an attempt to get the ovaries to do what they're supposed to do. You can see those ovaries on your ultrasound. And again, we're not going to talk about axis negative, anatomy negative patients. So now, let's go over each of these diseases individually so we can talk about both embryologic development and the HP axis. When you leave this lecture, you should have a good idea of embryologic development of male and female organs, as well as a good idea of the HPA axis. At the very end, to conclude, what we're going to do is review each disease on its own with the highlights and takeaways that you need for the test. Let's start with craniopharyngioma and Kallmann's. And let's start by looking at the axis. In normal patients, I'm going to get rid of these negative signs because we're not talking about them. The hypothalamus stimulates the anterior pituitary to produce FSH and LH. It does that by secreting GnRH in a pulsatile fashion. The anterior pituitary tells the ovary to make estrogen and progesterone, which turns on the endometrium to proliferate and turns on secondary sex characteristics, estrogen and progesterone. In both craniopharyngioma and Kallmann syndrome, you lose the hypothalamus. And in losing the hypothalamus, you lose the pulsatile GnRH. You lose the FSH and LH. And so you lose the estrogen and progesterone. Basically, you lose everything. And the critical finding here is no or low FSH and no or low LH. This differentiates it from Turner syndrome. So in craniopharyngioma or Kallmann syndrome, the pathology is in the hypothalamus. Either it's a mass consuming and blocking up the use of FSH and LH, that is, the body is trying to secrete the hormones that keep it alive and aren't really caring about reproduction. And in Kallmann syndrome, you just have a genetic deficiency. The patient is going to have a uterus, but because she's not producing any hormones, she's not going to have any secondary sex characteristics. It's diagnosed first by an FSH and LH level, which will be, of course, decreased, and then an MRI. Because the MRI is going to show you a mass in craniopharyngioma and no mass in Kallmann syndrome. And as a side note, Kallmann's syndrome is associated with anosmia. So if you see on your test anosmia and primary amenorrhea, Kallmann syndrome. The treatment is going to be simply replace the hormones she needs. And if it's a tumor, remove the tumor. This gave us a little introduction to the HPA axis. Before we talk about Turner syndrome, we need to talk about normal embryogenesis in order for you to fully understand how we bring in these other diseases. Let's talk about first what happens when you're genetically female. A genetically female individual will maintain the Mullerian ducts. And the Mullerian ducts will turn into the upper third of the vagina, the uterus, and the fallopian tubes. A genetically female individual will maintain her ovaries. And ovaries will produce estrogen and progesterone, which will cause development of secondary sex characteristics. A genetically female individual will default to the external genitalia of the vulva, vagina, and clitoris. A genetically normal male will replace those ovaries with testes. The testes will produce Mullerian inhibiting factor, which inhibit the Mullerian ducts. Mullerian inhibiting factor inhibits Mullerian ducts. They will also produce testosterone. Testosterone's main job in development is to take the vulva, vagina, and clitoris and turn it into a penis and scrotum. And by definition, because testes are made, there are no ovaries. So work with me now. A genetically female individual has Mullerian agenesis, an idiopathic reason for her Mullerian ducts to simply degenerate and are replaced with nothing. If a genetically female individual has Mullerian agenesis, what happens to the upper third of the vagina, uterus, and tubes? If a genetically female individual loses her Mullerian ducts, there are no vagina, uterus, and tubes. That same genetically female individual will keep her ovaries, will be able to produce estrogen and progesterone, and will develop secondary sex characteristics. That genetically female individual with Mullerian agenesis will continue to have her vulva, vagina, and clitoris. So she'll be all woman on the outside, she'll just lack female parts on the inside. That's Mullerian agenesis. Let's flip it around and talk about testicular feminization. In testicular feminization, you have a genetically XY individual who creates testes. The problem is that they have a deficiency in receptors of testosterone. The body does not respond to testosterone even though it's there. So a genetically XY individual produces Mullerian inhibiting factor. If you do produce Mullerian inhibiting factor, you block the development of Mullerian ducts, which means that this genetically male individual will not have the upper third of the vagina, will not have the tubes, and will not have the uterus. That genetically XY individual will have testes that produce testosterone. Testosterone can be converted into estrogen so that genetically male individual who has testicular feminization will produce estrogen that develops secondary sex characteristics of a female. That genetically male person with testicular feminization produces testosterone, but the body does not respond to it, so that vulva, vagina, and clitoris never turn into a penis or scrotum. So this genetically male individual has no Mullerian ducts, but does have estrogen and secondary sex characteristics, has external genitalia of a female. So she's all female on the outside, genetically male, and nothing on the inside, except that she does have testes instead of ovaries. If you didn't understand that, go back, watch that section again. It's really important you understand where this stuff is coming from. One more disease, and we'll review them one at a time. In Turner syndrome, She has streak ovaries. She is genetically female. Her Mullerian ducts develop, so she has the vagina, uterus, and tubes required to bleed. In Turner syndrome, she's genetically female, so she'll have a vulva, vagina, and clitoris. Her problem is that she has streak ovaries. She has lost the ability to produce estrogen and progesterone, and so will never develop secondary sex characteristics. So that is how you think through embryologic development in reference to testicular feminization, Mullerian agenesis, and Turner syndrome. Let's go through each of the diseases one at a time so that you have a better understanding of each one. Let's do Mullerian agenesis first. The pathology of Mullerian agenesis is an idiopathic loss of the Mullerian ducts. It is a totally normal female, except that for some reason the Mullerian ducts are gone. The upper third of the vagina, the tubes, and the uterus are never developed. The patient will have normal secondary sex characteristics. She'll have normal external genitalia. But she will have no uterus, and so can never bleed. But she still has ovaries. Everything is normal otherwise. The diagnosis can be made on a karyotype demonstrating that she is XX, and because all of her endocrine function is intact, she will have a normal testosterone level. If you assess it, she'll have a normal FSH and LH. The treatment for her, because she is endocrinologically intact, is simply to make her life a little better. She'll have a short vagina, and so sex will be uncomfortable. You simply need to elevate the vagina and counsel her that she will never be able to get pregnant because she does not have a uterus. If we compare that to testicular feminization, and what happens is in the title, it's woman looking despite having testes. The path is that the body is resistant to testosterone. There is a genetically male individual who produces everything the same way, has testes, but looks female. The patient is going to be endocrinologically intact, so will have secondary sex characteristics. The external genitalia is that of a female. She will grow up a female, but she will have no uterus because Mullerian inhibiting hormone is still functioning. She will grow up a female, her identity will be female, but her genetics are male. The diagnosis can be made with a karyotype demonstrating XY. Because the body knows that it should be producing testosterone to change it. There's no feedback from the testosterone being made because there's an insensitivity to testosterone. The testosterone level will be elevated. If you assess it, the FSH and LH will be normal. The treatment for her is still to elevate the vagina as you did before, because now she still has no upper third and sex will be painful. But because she has testes, which have not descended, she is at risk for testicular cancer. So what you do is allow her to go through puberty. And after puberty, at about 21 years old, you remove the testes. Let them do their job in developing her into an adult female, but then remove them early to prevent them from turning into cancer. Finally, we're going to close with Turner syndrome. Turner syndrome is a genetic disease the patient is lacking a chromosome. In this instance, her only problem is that her ovaries are actually just streaks, non-functional fatty streaks. The patient has a genetic syndrome, and so you're going to see all of these at the same time. She'll have a webbed neck, a broad-spaced nipples on a shield-like chest. She'll also have some cardiac issues, which you'll need to investigate, and you may hear a murmur. To diagnose this, you can get a karyotype, which is usually XO, but it can be normal XX. Her FSH and LH will be elevated. The hypothalamus stimulates the anterior pituitary, which stimulates the ovaries. The ovaries are gone. The feedback inhibition from estrogen and progesterone, which would turn off FSH and LH as well as GnRH, is absent. And so what happens is that GnRH increases. FSH and LH increase in an attempt to increase the ovaries. But unfortunately, there's no ovaries there, so they just keep increasing, trying to induce estrogen and progesterone, but can never do it. And an ultrasound will show fatty streak ovaries. This patient is deficient only in estrogen and progesterone. She needs estrogen and progesterone so that she can develop into an adult woman and not be trapped in a child's body. And as a follow-up, because of her known cardiac issues, you need to do an echocardiogram. What you are looking for is congenital cardiac defects, such as coarctation of the aorta and transposition of the great arteries. So hopefully at the end of this lecture, you now know a little bit about the rare diseases that cause primary amenorrhea. You have a working method to kind of work through the axis and the anatomy. The most important thing for you to do is simply remember what you need to do for each disease. Testicular feminization is genetically male, female on the outside. She will be a woman for her entire life. Elevate her vagina. Mullerian agenesis, she's all female. She's just missing some parts. Elevate the vagina. In Turner syndrome, if you do not give her estrogen and progesterone, she will miss her opportunity to develop into an adult-looking person. And finally, the really rare diseases, Craniopharyngioma and Kallmann syndrome. Keep an eye out for anosmia and primary amenorrhea to get the diagnosis of Kallmann syndrome. That's primary amenorrhea. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.